So today I'm going to be talking about advanced toxins. First is the exception to the use of preserved saline when reconstituting your toxins. The second is the cautionary tale on chasing the crow's feet. So how many of you are using bacteriostatic or preserved saline to reconstitute your toxins? Everybody. We'll actually be hearing some interesting controversies about compounding that's considered compounding. So this was first reported in 2002 in a double-blinded randomized controlled trial by Murad Alam in 55 patients, and they found the benzyl alcohol actually reduces the pain without changing the efficacy, and all consensus panels in the last 10-15 years have agreed. However, there is one caveat, is that you can have a delayed type for hypersensitivity reaction because of the benzyl alcohol. So if you see a patient and a few weeks after the injection, they develop an eczematous dermatitis in that area, you may want to send them for patch testing. And in those patients, you do not want to use preserved saline. It's also important to know this is off-label for all the approved toxins, and so that should be documented as well. The next thing is chasing the crow's feet. So there's a lot of different patterns for crow's feet, but a lot of patients have the fan pattern and an inferior pattern, and they'd ideally like to have the after picture that we see here on the left. But that's hard to achieve, and after patients come back at 2-week follow-up, they still have the inferior portion that they want treated. It's important to know that the zygomaticus muscle is divided into two parts, the major and the minor, and the inferior portion actually inserts into the bicularis oris muscle, and it is adjacent to the bicularis oculi muscle near the eye. So when injecting, it's really important, and all of you guys do this here, is smile. So you want the patient to smile and relax, and so you can feel the muscle insertion right on top of the bone, and you want to make sure that you don't inject there. A little point is that the abicularis muscle is more superficial, so that's another reason to inject more superficially, but you want to avoid injecting more inferiorly for those patients. So the question is, inadvertent injection causes what? So we know here in this patient that when you inject, you actually are unable to smile on the ipsilateral side of the injection site, and you're unable to fully open the mouth because remember the insertion into the bicularis oris. So those are two things you're not going to be able to do. And the potential treatments are injecting into the contralateral side when you see the patient at 2 weeks, or resolution usually happens at about 2 months, so you can wait for those patients.